This is part 2, qualitative methods and sampling. The learning objectives are to describe types of qualitative research methods, describe mixed methods designs, describe an appropriate qualitative research question. There are different strategies of inquiry in qualitative methods, and we're going to talk about, really focus on the first 4 that are going to be presented here. So clinical research, which is what most of the folks who are participating in this lecture are probably going to be focusing on. Ethnography, which is more what I was describing with my dissertation research. Phenomenology, which is, we'll get into that in a little bit. It's looking at the lived experience of a particular thing, like the lived experience of being in a critical care unit as a patient, a particular kind of patient at a particular point in time. Participatory action-based research, case studies, narratives, grounded theory. Narratives and grounded theory we're not going to really talk about here, but narratives is more where you ask somebody to tell you a story. You could ask them to tell you the story of their experience with cancer and ask them to maybe divide their life into chapters in any way that they want to, and then they could tell the story. Or you could do without the chapters. And what you want to see as someone tells their story, people usually doing narrative research want to see the trajectory. Do they start out saying life was really good and then this particular cancer experience happened and I fell down to the depths of despair and then I arose again, basically from the ashes and my life's fabulous? Or does it go in a different trajectory? And then you would want to see if you could maybe interview enough people that you could find out that maybe there were typologies of people and particular cancer experiences that you would be able to understand about what had happened and how it had played out and how people understand it. And you might be able to develop some sort of an intervention around that. Or, and sometimes it's just basically research where you're just trying to tell a story of something. And it isn't necessarily, the point isn't necessarily to design an intervention. Grounded theory, constructivist grounded theory that Kathy Sharma is doing is really where you're doing this question, the grand round sort of question that I'd mentioned before, like tell me your life before HIV/AIDS, tell me your life after, and you basically are quiet while they tell you that long story. And what makes something grounded theory research is where you're actually a team of folks. The original way that it was looked at when it came out in the 60s and 70s was to have a team of researchers and maybe looking at 60 interviews like this and coding line by line and trying to find out what's the meaning of this line, not even the whole sentence. What's the meaning of this line? And having 5 or 6 people around a table discussing it and really getting into that. And then having all these codes and coming up, the point was to maybe come up with theory at the end of that. I think that's Kathy Sharma has changed this more into constructivist grounded theory and something that's, I think, more doable for people in psychology and clinical medicine. But I think people need to be really careful if they say they're going to do that. Most people say now they're doing a grounded theory approach, but it's a territory that you need to really do a lot of reading on, and I wouldn't just claim you're doing grounded theory because most of the folks that I know are doing a type of clinical research and they're doing thematic content analysis, and then they'll say they're doing grounded theory, but they're not. They don't know what they're talking about. So you want to avoid that if you can. So you want to match your research topic to the appropriate research approach. So here, for example, here's a question. How do patients, families, and providers manage or not journeys to and through palliative care? So this is the point of this kind of research is to find out what's actually happening on the ground. So you might have a public health researcher or a clinician walking into it and assuming there's a particular kind of journey or there's a right way to do palliative care and the transfer into hospice, and they want, to lay this ground work for doing this sort of thing and have a survey to ask questions. But I think it's nice to step back and find out first what people think is actually happening, or to have them tell their story about how it's happening. And I think the patients tell one story, their families have another one to tell. So we could say family/caregivers have another one to tell because they're being impacted in other ways. And then the providers themselves, and we could divide that group up into many different, so the social worker, the nurses, the physicians, and other people that are interacting with the patients. What impact do they have on that journey? And how much do they work together or not? How is decision making made? And it plays out in 100 different ways in all these different settings. So that's one. So how do you look at that? How do you get at that? So one way is clinical research approach. Another way is an ethnography. Another could be a case study. These terms are appropriated by different disciplines, so it might be confusing sometimes when you look at different books about how to do qualitative research, because depending on the discipline and the decade that it came out, they might be claiming to do the same thing and be different. So just sort of think about that as you're getting ready to decide how you're going to write up a grant or how you're going to do your analysis for a manuscript and how you're going to write up the method section. So clinical research, by that I mean what's actually happening in a clinic or a hospital setting. So you might be wanting to actually look at the patient-provider interaction in that sort of situation. You might want to be doing in-depth interviews that will help you create your survey, that you would want to ask people about what's happening or not happening as they make these decisions. You might want to interview nurses and physicians to see how they're managing it, or if they are managing it, and what are the politics of those particular things, and how much power do any of them have or feel that they have or perceive that they have in those sorts of situations. You could also be doing the same thing and call it an ethnography, but what would make it an ethnography? Clinical research would be for me, more, you're actually just doing a sets of interviews with these different people. What makes something an ethnography is that you're actually doing an observation in addition. So you're hanging out in the hospital and you're watching how it all works out. You may not be part of the patient-provider interaction during a physical exam, but you could still be watching how nurses and doctors interact, what they're saying in their study groups, or decisions about particular how people are going to manage the treatment of a particular tumor for a particular patient, that kind of thing. Hanging out and being part of those discussions and learning how people talk about different things is what makes something an ethnography. And taking field notes and writing it all down and observing yourself and how you, as a researcher, are changing as you learn more about what's going on in that research study. And a case study would be more bounded. So you'd be actually looking at, one example is that a student has, he was looking at mistakes that happen in a hospital. And how was it dealt with, and what were the chain of commands, and what were the responses to it. And he was actually just collecting data for something in the past, trying to find out generally what people's responses were and how they were dealt with. And in the middle of his research, a mistake happened. And so he was able to actually be on the ground and watch the entire situation play out. And actually his thesis is embargoed, so because it's part of the legal process. So that case study of what actually happened is bounded by all the participants that were part of that mistake and how that played out. So that makes that a case study. So another question could be, what is the lived experience of a person living with HIV-related cancer in a low-resource country? And if you really want to know the answer to this, you can look at Julie Livingston's book. She's done a fabulous book on looking at how one of the first cancer wards in Botswana, and what that experience was like for the people who had AIDS-related cancers and were showing up in a setting where there wasn't really much of any resource for them. So the way that you could do this is a phenomenological approach and an ethnography. She used both. She followed people around in the clinic, and she also followed patients home. So these patients didn't have any opportunity to take any antiemetics, so that she was actually with them at the bus stand while they were vomiting after they'd had their radiation or their chemo, and they still wanted to come back. And they still, had to go home. Some of them were being treated as outpatients. And she talks about their pain and how they describe pain and how they engage with the doctor and how the doctor manages his tiny little setting. And so the phenomenological approach is about getting at that lived experience of being in that clinic. I can't remember off the top of my head how many people were in that ward, but there weren't many, and they had to manage them. So as soon as somebody had the treatment that they needed, they had to move them out and get somebody else in. So it was, what was the lived experience of being in that clinic at that particular point in time? The ethnography is adding the observation and all the field notes to it. So with the phenomenological approach, you could be just interviewing them all and not doing the observations and or the field notes and following them around. How do we work with communities to improve their health-related concerns? This is the participatory action-based research. And some people call this community-based research, but when you're doing community-based research, you're not necessarily doing action-based research. Action-based research is where you're actually working with the community. They get to identify what the problem is. You're part of that process, but they're the ones deciding what the issues are, not you. So you aren't coming in with some earlier based idea of what to do. The different kinds of methods, I've sort of mentioned them already. In-depth interviews. There are informal ones, unstructured ones. So informal would be more like you actually don't have a set of questions that are very detailed. You might have 5 questions about what it's like to have cancer in this community, but you would have more opportunities to have informal interviews where people would tell you more later. And they might be taped and they might not be, depending on the permissions that you've gotten with that, with the IRB and with the population that you're working with. Unstructured is that you would also let them move in new directions. For example, at the end of mine where I'm saying, tell me if there's anything I didn't cover that is new that's happening in your community, or because I'm not here all the time. If that takes you in another direction, those are sort of unstructured interviews but you have to write up your IRB so that you say you're going to follow that sort of approach. Semi-structured is more that you have this set of 10 questions with their probes, and you're asking everybody the same question, same set of questions, but you have to pay a lot of attention. You don't follow like you would with a survey. You're not saying, when you get to interview 4, if they answered, question number 4 while you were doing interview question 1, you don't repeat it. So you have to really pay a lot of attention, because you can ask somebody a question and they don't answer just the question you asked. They could be answering question 5, 6, and 7. And so you better be, with your little sheet, ticking those off so you don't waste time asking them again, or they'll think you're not paying attention and they might get mad at you. So you have to be really on top of what's happening. So you don't have complete control. People, you might ask one question and they answer another one just because the question you ask them, they feel is too personal, or they don't think it's any of your business, and they're not going to tell you. Focus group interviews are meant to be with a group of people who do not know one another. So if you're actually in a situation where you want to interview a bunch of nurses on the ward, that's a group interview. That's not a focus group interview. I think there's a lot of confusion about that in the research world, but they were created by market researchers, social marketers that wanted to sell orange juice, and they did a really good job. Obviously, we now, 1950s, we all kind of have. Well, I don't, but a lot of people have orange juice for breakfast. So you want to screen before you do these kind of interviews and make sure that folks are willing to talk about the subject that you want to do the interviews about, that they are informed about the subject, that you want to be getting people from different places so they don't know one another. Because if they don't know one another, they're more likely to feel, the idea is they're more likely to feel comfortable giving their opinion, because they don't care if they're being judged by someone else, because they're never going to see them again. In a group interview, like I said, it's people who know each other. And there's a lot of interesting things that can happen. And a lot of times in-depth interviews turn into group interviews. You might be, for example, in my situation, I was here at MD Anderson wanting to interview ovarian cancer patients, and many times they weren't alone. The one or two times they were willing and felt well enough to have an interview, their mother or their sister or their husband was with them. And it wasn't necessarily a bad thing, actually, because what happens is they help prompt them. They might forget something. And they'll say, well, remember that one time? And then they'll kind of draw them into the conversation. A bad thing is that they might not want to talk about other things they don't want that person to know about. But you just have to kind of look at it as an opportunity to do what you can. You're not maybe ever going to get that patient again to interview. They might not be available the next time you come. So you just have to, when you get to the point of writing up your research, you just say, I had 20 in-depth interviews planned. 16 of them actually were in-depth interviews with one person, and 4 of them turned into group interviews where in one situation the husband was there, another situation the sister was there, and then you just move on with them. So it's fine. It happens. It's just that we have to write it up that way. With observation, I've mentioned it before, what observation is. So it can be in the clinical setting, like I mentioned before, where Julie Livingston was working in Botswana in the clinic. And I'm mentioning her name again just because I think this is a fabulous book, but also she was a recipient last year of the Genius Award. So qualitative researchers actually managed to get recognized every once in a while. And it's a great short read, so everybody here should be reading it. But there's observation where you're hanging out and watching and following people along, and there's participant observation, which I didn't actually write down here. Participant observation is where you're actually getting involved with the community in a particular project. So, for example, one of my students was, for the class, they all go do their own research project, and hers was with a community that, a clinic that actually had very few resources, including very few staff. She walked in and they would always have files sitting around, and they didn't have enough people answering the phone. And one day she asked if they wanted any help, and they're just like, yes, please, start filing these things and answer the phone and directing people. Within a week, they were calling her and saying, this is actually a refugee service agency. Within a week, they had decided that they wanted to bring her along. There's family coming, do you want to come with us to the airport? And so she was able to get in with the community in ways that actually my students can't anymore. There are too many people doing this, too many students now that want to do this from all over Houston. So this particular agency is really swamped with student volunteers. But she was one of the first people that did it, and after the class was over, they asked her if she wanted a job. So that was her summer job before she started her doctoral program. So participation means you're actually doing something with the group that you're working with. In archival research, I mentioned this earlier with my dissertation research and working in the archives, looking at district officers' reports or land, tax files, hospital reports, annual records. So you can also be looking at patient records in your own particular hospital or clinic setting. That if you want to go back and see what was happening in the 80s and how did they first start to understand, the Kaposi's sarcoma, how did it look, what did people write about when they first started looking at it, if you could go to maybe a particular hospital that had a lot of cases early on. Then just reports, looking at the same sort of situation, you could look at CDC reports about that or any other annual reports that were talking about that. In the newspapers, how were people talking about this gay disease and how it evolved over time, how people were understanding it. And even letters that were being written. If you're actually going to an archive, a lot of the archives that are holding medical archives have letters from doctors to one another or letters that they're sending maybe to the Cancer Institute. And one of the things that could happen if you're doing maybe just a history of the creation of MD Anderson's Cancer Center, there's a lot of information in the McGovern Historical Collection here. And they hold a lot of records about rheumatoid arthritis and about Hiroshima and the bomb, and the radiation experiences from that. So you could go and find letters to government agencies, doctors, to one another, other researchers in that sort of a situation, and be able to pull these interviews maybe with somebody, hanging out, maybe even doing a group interview with a number of the folks that were involved in creating maybe MD Anderson or maybe who had worked on other projects that you're really kind of focusing on. So you could combine all of these different methods in a study. It just depends on what your project is and how much money you have and how much time you have, and does it fit really the question that you have. And then you can also be doing looking at social media, following Twitter, visiting chat rooms. There's, for example, virtual bars where you can go in and hang out. But people who are doing ethnographies of that sort actually go in, and the ethical way is to announce that you're there and ask for permission to lurk, basically, or even interact. So all of these are sources available for people to use when they're thinking about what they want to do. So you have to think about, when you're selecting your research topic, what are the right methods for you? When and where can you use them? Think about your funding again. Because the other thing is just the basics of getting your recordings transcribed if you're not going to do them yourself. And they can take 6 to 8 to 10 hours to record to transcribe an hour of interview. How much money are you going to have to be able to do that? Who's going to do that for you? So anyway, so this question of how do these patients, families, and providers manage or not their journeys through palliative care? You could use, again, the clinical research ethnography case study. The methods for those would be in-depth interviews. All of them would use in-depth interviews. You could use observation. And then it turns it into an ethnography. If it's a case study and you actually happen to be there when it happened, then you could call it observation. But if you're coming back later, clearly you're not using that. But if there's these things that are happening while you're there, so you could maybe observe patient-family interactions, there might be a workshop at the particular place you're working that's on palliative care decision-making, and you can see the kind of questions that providers are asking, how the particular person who's teaching that lecture is presenting it. So that is what constitutes observation. Focus groups could be used. You could get, if you were able to get people from different hospitals, or if the hospital was so large that you could get people from different units that didn't know each other, then you could do focus groups. And you want in your focus groups, and even in your group interviews, you have to be really clear about who it is you're interviewing. And I'll talk about sampling in a little bit. In group interviews, we already talked about patient records again. You can be going through your patient records. All of these things will help you understand how people are going through this journey through palliative care, because in the patient records there might be discussions between the physicians or the nurses or whoever, the interns. All of these people might be writing different things that hint at this is the process or this is the way it should go forward, and you can see how it plays out in the notes there or doesn't. And then their absence of notes can tell you something too, or it's something that you can explore. And then again, you can newspaper and social media reports and comments might be available. It just depends on what your study's about. So if you're really concerned, like for example right now about PrEP, pre-exposure prophylaxis for HIV prevention, you're probably going to be able to find a lot there in social media reports and comments. Different organizations right now are taking stands on it. So right now, Sex Workers International has said they do not want PrEP and they don't support it. And they're actually being targeted by international agencies as they're seeing themselves being targeted as maybe objects of concern, that they're going to, that they're the key population that's going to spread this virus. So we have to make sure that they're taking this pill every day for the rest of their life so they don't spread disease as if they're diseased objects. So they're rejecting this, and so are injecting drug users. They said they don't want a blanket policy like that focused on them. So that's the kind of thing you can find in those newspapers, social media reports, if it applies, that can be useful. And then how do you select an appropriate topic and the methods that are right? Again, with this question of what is the lived experience of a person living with HIV cancer in a low-resource country. The key to knowing something is a phenomenological project or a study is that they say the lived experience. That's what people care about when they're doing this kind of phenomenological research. You can do this again with the ethnography or the phenomenological research. The methods would be in-depth interviews, which is phenomenology, but it's also ethnography. Ethnography is including the in-depth interviews and the observations. So it's looking at the clinical encounter. It doesn't have to be all these things. It can be any of them or even one of them. Spending time with the patient as they go through their day at the clinic, patient-family interactions. There's all sorts of things that are going on. One of my students decided to do her study on Ronald McDonald House and what was happening there, and was able to find out a lot about the difficulties that families face when one parent stays with the child who has cancer and the other one has to go home and manage the rest of their life. And the difficulty of doing that, especially here where a lot of people travel a long distance to get here, so it makes it really difficult for the families to reunite very often during that time period that their loved ones in the clinic or in the Ronald McDonald House and coming back and forth for their treatments. Group interviews for the ethnography again, patient records, diaries, memoirs, social media reports and comments. So a lot of people these days, I mostly am focused on drug research right now, and there are a ton of personal memoirs about drug use experience, people who have managed to quit, people who are partners of people who didn't manage, or and that journey. They tell the stories, they tell all sorts of things in these, and they're really useful sources to sort of understand what was going on and to understand the time period. They give you a lot of information about what was going on. Some of them have been frauds, as whoever, I can't remember the name of the guy, I think it was James Fry on Oprah, was exposed, but not all of them. So they provide useful information. So when and where, again, so with how do we work with the communities to improve their health-related concerns? And this is participatory action-based research. You have initial meetings in the beginning with the community to identify their issues of concerns. So if someone is doing clinical research and wanted to stay focused on cancer, one way to do that would be to meet with a community of survivors of a particular type of cancer and try to find out what their issues are. So I think for men and women who have received a lot of radiation for bladder cancer or anal cancer or cervical cancer, issues about sexuality would be really important ways to kind of beginning. These are issues, as a cancer survivor myself, I can tell you these are major issues of concern for that particular population, worried about their second cancers, who exactly is more likely to get it, when will that happen in their lifetime. And people are sharing information very informally, so you might want to find out how they're doing it, how do they manage their sexual lives post-radiation, and this is something that people are very concerned about and talk about a lot. I don't know how often they talk about it with their clinicians and their nurses and their doctors. So you could have in-depth interviews with the key stakeholders, and that could mean the cancer docs themselves and the nurses, and it can mean the survivors or the people who are getting ready to go through the procedures that haven't gone through it. All of those folks are key stakeholders. And then working on the community that they've on the problem they chose. So you may want to work on sexuality, but if that community is really doesn't want to go there, then that's not the topic that you're going to pursue. So, and then you engage in participant observation. So you're spending time and working with the communities. They do different things, like maybe they decided, we really need a community garden. Third Ward here in Houston has a food desert. This is a historically African-American neighborhood. And they also had a project actually where they remodeled derelict homes. And actually on Holman Avenue here, you can find a museum now that's set up. Some of these were transformed into a museum. And our local historian who did that actually also got a MacArthur Genius Award. So anyway. So developing teen community centers, if that's what they decided that they need, writing and staging a community play about the harms of interpersonal violence among youth. Any of those things might be the outcomes or part of the process of moving with that community about what the kind of thing that they want. So they might want, to transform the look of the neighborhood. They might want the teen community centers. They might want any of these other projects. But together you've decided, and they've led it. Which is what's really important. And then focus groups when appropriate, or maybe it should be group interviews when appropriate. It depends on how big the community is and whether or not you could really do a focus group so that people wouldn't know each other. And then again, group interviews. And then looking at the newspaper, social media reports and comments, files from local archives about this, because you'll be able to find a lot about the need for some sort of community garden or a teen community center, probably, and write-ups about crime and violence or about the food deserts that are in the newspaper. There was just something a couple days ago in the Houston Chronicle about the food desert and how the city's going to rebuy some property from Houston Community College so that they can rent it to one of the local grocers and actually respond to the problem of food deserts in Third Ward. So let's go to sample sizes and say a little bit about that. I've talked here about in-depth interviews and needing 20 to 30 in each subgroup for most clinical and public health research. But that's not always the case. So it's really important, I think, for you to read a lot more about samples and know for your own particular research approach. For phenomenology, you're not going to do 20 to 30 interviews because there probably aren't 20 people who were in the cardiac care unit in March when you went to go find out about that experience. So maybe there were 7 or 8 or 10 that were there at that point in time, and you were able to talk to them about what it was like to be in that particular hospital with that particular crisis, in their care and their lived experience of that ward at that particular time. So that's for phenomenological. But in in-depth interviews for something typical like this one, where this is actually from the study that we had here. You're interested in talking to ovarian cancer patients. You might want to say by a particular stage. You might want to say by a particular age group. Or you might want to divide the group into ethnic components. So in this situation, we're talking Hispanic, Black, and white, and saying that you want to do 20 interviews with women who are between the ages of 40 to 49, who are Hispanic, another 20 with African American, another 20 with white. And then in the age group of 50 to 60, you would be doing, again, 20, 20, 20. So the important thing, or 20 to 30. So we actually wrote up a grant where we were doing 20, 20, 20 for CDC, and they said, we love it, we really think it's important. We're going to give you enough money so that you can actually do 30 within each one of those categories. But often, a term actually from grounded theory that I'm not that comfortable using, but everybody is using it, is called saturation. And that's usually what it refers to is you're doing interviews and you're hearing the same thing over and over again. And so often that happens when you've done 20 interviews with ovarian cancer patients who are Hispanic. Now, I wouldn't say it's happening when you've done just 20 with all 3 of the groups. You still need to do more interviews. So you would end up with 60 interviews. Or that might be just the story for that particular age group. But it's really important for this kind of clinical research or public health research where you're really focused on a question of maybe you're trying to get at the symptoms of what ovarian cancer patients are experiencing that led them up, everything that led up to diagnosis. And I'm not making this up, this is actually our study. So we wanted to know for the women that were at MD Anderson at that particular point in time, or anywhere in the Texas Medical Center, that were diagnosed. No matter what stage they were diagnosed at, we wanted to collect all the information that we could about their diagnosis. And it was a really interesting journey, because many of them went from pillar to post to a number of different physicians before they were ever diagnosed. And they were diagnosed pretty late stage when they had a big tumor. And then if you're going to do focus groups with ovarian cancer patients, again, you need to have 3 focus groups with each one of those groups. So we're in the one above for in-depth interviews where you're doing 20 to 30 for each one of those different groups. Here you need 3 interviews, 3 focus groups with Hispanic populations of a particular age, 3 focus groups with Blacks of a particular age, and then 3 with the white population of a particular age. And then if you're concerned about age, if age matters, or if ethnicity matters, if you decide I'm just going to go into this high school and I want to know what all these kids are, pretty much the same. I'm going to Minneapolis. They're all Norwegian descent, last name Smith or Larson. And, there isn't much difference between these kids. All the kids are from a particular socioeconomic thing. You might want to do 3 with boys and 3 with girls, or you might want to divide them up by age groups again, so that you would have, if you were doing junior high, you might want to have 5th graders and 6th graders or 7th and 8th graders in different groups, because they're going to be different according to their adolescent experience. So you have to pay attention to that. So you just have to really know your population and know what's important and whether or not there is something that in this particular community, the lived experience or just the experience of being an ovarian cancer patient is going to play out differently. And for us, in a way, oftentimes being Hispanic or Black or white is a proxy for insurance sometimes in the community. So sometimes you might not care so much about age or even ethnicity. You might want to care about SES, especially if you're focusing more on health disparities. And you just want to realize, look at how did it change up. You might want to be looking at how things changed with Obamacare and whether or not more people are coming or fewer people are coming and who's getting access to what in a particular state. Okay, so Doing mixed methods designs. There are a number of different ways to do this, and we'll talk first about the priority sequence model if you're going to do this together. So if you do the quantitative first, the qualitative first, they're showing you here in the slide this qualitative, and it's preparing you to go into the quantitative. So that's like my initial research with the drug users in Tanzania I did 50 in-depth interviews so that we could change the crack cocaine survey from Houston into one that was useful in a Tanzanian setting with heroin users, heroin injectors. So we found out what people were doing. We were able to change the survey, and then, so we did the qualitative first, then the quantitative. We did the survey. And you might want to switch it up. You might want to do the quantitative first and try to get an idea of the magnitude of a particular problem and then go in with the qualitative. So in this case, the smaller qualitative study is guiding it, and then the second case, the smaller quantitative study guides the data collection. So in the first, in the quantitative, you can generate hypotheses, develop content for the questionnaires, and in the second instance, where the larger study's qualitative, the survey could have helped you with the purposive sampling, establishing preliminary results that you really want to focus on in depth. So again, with the flash blood, you'd really know what part, if you had a survey, you'd know what part of the city that people were doing this in and who in particular was doing it at that point in time. And we have different examples here. So the first one could be focus groups to shape a new health promotion campaign, and then in the qual, you could be doing a survey of different units in a hospital to locate the sites where you would want to do the more extensive ethnographic data collection. In a mixed method priority sequence where you do the follow-up, you could do it the other way. So you have a qualitative follow-up or quantitative follow-up. You begin the larger project as a quantitative with the qualitative at the end, or you have a larger qualitative with a quantitative end, sort of like my dissertation study where I told you it was qualitative at the end. I decided to do the survey. So they help you, each one of those helps you evaluate, interpret the other study, the larger study. So it can help you with interpretations for poorly understood results or outliers. One of the things that we really like in qualitative studies is when there are outliers, we want to follow up and track down those outliers and find out why are they outliers. So we don't try to take them out of the study. We pursue them to find out what's going on and why they aren't fitting in, and what's different about them and what does that mean for our work. In the qualitative, you can generalize the results for different samples, test elements of emergent theories, and so on when you get to the quantitative stage. And another one, here's an example for the quantitative. The in-depth interviews could help you after the survey explain why one clinic is getting higher levels of patient satisfaction than other clinics. It could be that they have really a fabulous receptionist, or the physicians there are somehow more connected to that community, and they're conveying that in their interviews with the patients or the times that they're spending with them. And the other one is the example that we have here is the statewide survey of school-based health programs that is done after you've done a case study. So you've done this in-depth, little case study of what's happening in one particular part of town of a large, or a city like Houston, and then you decide, okay, this is what we found here. Let's do this statewide survey and really find out how it plays out. This school-based program that we've just designed. And then you have these mixed method designs where you have concurrent triangulation strategies. Triangulation is a word that's used to talk about basically how you look at one method and pull them all together to synthesize information that you've collected. So we've collected all these different information from the survey, from the observations, from the interviews, and they might not make sense until you spent time actually looking at them and seeing how one informs the other. So, for example, me looking at my pregnancy history survey and going back into the community and talking to them. Now, you can't always go back and talk to them, but it would help to inform it. So it's sort of like, well, this is what they told me in the field, and then I did this, and I did the survey, and it didn't play out that way. So you have to sit there and sort of tease these things out and come up with some sort of explanation that explores all the different reasons for why that's not there. So it kind of demonstrates why you don't want to do one or the other, and why it's really important to do both so that you can understand. Because what they might be telling you in an interview is the way it used to be, or the way it should be, and the way that things are in the logical world, but not really the way they're actually happening. And somebody might not be able to fill out the survey properly because the questions aren't being asked right. So you might have a really lopsided set of answers in your survey that you can't really understand or explain when you get to the end. But if you go back and do the interviews with folks and you have gained their trust and they feel that they're comfortable telling you, they might be able to explain why the survey came out the way that it did. So you can do it if you're doing it quantitative and qualitative at the same time. You will, as you begin to analyze it, having them, this approach actually wants you to analyze them together at the end. But I always think that you should be doing your qualitative analysis from the very first interview. So you want to send that off, get it transcribed, and start coding it, and we'll talk about that in the next section. But then in your quantitative data analysis doesn't always wait till the end either. So you might be doing the first 100 interviews and then plugging that in and looking at that and how is that playing out and comparing that to the information that you're getting as you go along. So you're comparing the two. With a concurrent nested strategy, you're doing them at the same time, but the qualitative, for the one where the qualitative smaller part is nested in the quantitative, you're looking at the analysis sort of all at the same time. So an example of this with this qualitative inside of the quantitative would be where you're doing a survey, but at the same time you're actually interviewing stakeholders. So maybe you're working with physicians in a hospital on a particular project and you're surveying them. You might want to go into and interview particular sets of physicians or nurses that are in a particular hospital or in a particular ward that would be able to give you more in-depth information about that particular issue that you're really focused on. So that, for example, you could have stakeholders that you were interviewing about cancer survival, and the larger survey might be about cancer survivor issues. So you'd have those two things to look at. And then with the second sort of block that we're looking at, is a larger qualitative study, and inside it is the quantitative. So you could be doing this ethnography and trying to follow a community over maybe 6 months and truly understanding, how this is working out. Again, maybe hanging out with a bunch of cancer survivors, trying to figure out how they are managing life 1 year out, 2 years out, and the different issues that come up. And you could do a small survey where you would actually be able to maybe have an online survey that would, if they had told you about a chat room that they have, there's actually a lot of Yahoo user groups of cancer survivors where they're talking to each other about all these different issues. So you might be able to send them an invitation to an online survey that you would have and see how many would answer it, and you'd have that available. So this is the end of section 2, and now we'll have a short quiz.